551. Eculizumab is a new agent under investigation for the treatment of PNH. Which of the following statements regarding eculizumab is correct? Okay, so eculizumab is given to a patient of PNH, and which statement is correct is the statement E. Vaccination is needed before starting of this medicine. 2 weeks earlier, we have to vaccinate the patient against the Neisseria. Why we do? Because it is a anti C5. Okay, and it blocks the complement pathway. It blocks the final steps of the complement pathway, and due to that, these patients are prone to get infections by encapsulated bacteria. So for that, we need to vaccinate the patient and give them an meningococcal vaccine 2 weeks before therapy. Okay, so option E is correct, others are wrong. Next is, which of the following organism is the most common cause of osteomyelitis in children with sickle cell disease? So with sickle cell disease, the causative organism of acute osteomyelitis is Salmonella species. Overall, if there is no in the population, Staphylococcus aureus is the one causing osteomyelitis. If there is no sickle cell anemia, so then this option would be correct. But if it is sickle cell anemia, so then you have to select the option C, Salmonella. Next is beta thalassemia major and intermediate may be associated with many complications. Which one of the following is not a complication of the condition? Okay, so I think so it should be beta thalassemia intermediate, so that will be more specific. Okay, so which is the not complication of the condition? Gallstones, hypothyroidism, leg ulcers, priapism, and venous thromboembolism. So for hypothyroidism is not a complication of thalassemia. Okay, neither major nor intermediate. So option B is correct here. But just let me explain something. If you see leg ulcers, priapism, and hypercoagulability in a clinical scenario, so think of sickle cell disease first, okay, because of the hypercoagulable state, because of the microthrombitis. So that these patients are prone to these conditions, these symptoms, which are like leg ulcer, priapism, hypercoagulability picture. So, but these are also associated with thalassemia, beta thalassemia intermediate, non-transfusion dependent one. Okay, especially if the patient is older, non-transfused, and the spleen is removed from that patient. So having so just remember these two differentials of these symptoms. Okay, so beta thalassemia intermediate is also a hypercoagulable state. Next is, the following is the result of high performance chromatography hemoglobin analysis performed on a woman at her first antenatal checkup at 12 weeks pregnancy. HbA2 is 52, HbA is 2.3, and HbF is 8%. Her hemoglobin is 9.2, MCH is 24, so it is a case of microcytic hypochromic anemia. Which one of the following is the diagnosis is most likely? So just go see here, HbA is reduced, so of course it is a case of thalassemia. HbA2 is normal. If HbA2 is normal, so it is not a beta thalassemia trait, and HbF is 8. So in we studied earlier, like in whenever there is delta beta thalassemia, HbF would be 5, between 5 to 20%. What is the why it is called delta beta thalassemia? It means like in delta there is deletion of delta and beta chains. So when there are no delta or beta chains, or there is reduced delta or beta chains, so what will be the compensatory increased, in which chains there will be increased gamma chain production. So when gamma chain combines with alpha chain, so there will be production of HbF. That's why in patients with delta beta thalassemia heterozygous, these patients have increased HbF from 5 to 20%. HbA2 value is normal or slightly reduced. So this is a case of delta beta thalassemia. Okay, so HBE, I will explain the HBE in this scenario. So which case, like how HBE trait looks like on HPLC. Okay, then there is hereditary persistence of fetal hemoglobin. Yes, in this case also, if the heterozygous one I'm talking about, HbF is raised, it is about 10 to 30%. It is 5 to 20%, it is 10 to 30%. But what is the most important thing, the indices will be normal. Okay, in HPFH, the indices will be normal, patient will be asymptomatic. So just remember, in the DDs of heterozygous delta beta thalassemia, the heterozygous hereditary persistence of fetal hemoglobin. The following is the result of high performance HPLC analysis performed on a woman at her first antenatal checkup at 12 weeks pregnancy. Hemoglobin age 59, A2 is 32%, HbF is 3.2%. Her hemoglobin is 9.2, MCH is 22. So it is a microcytic hypochromic anemia. But which one of the following diagnoses is most likely? So it is these options are given: alpha thalassemia trait, beta thalassemia major, beta thalassemia trait, HBC trait, and HBE trait. Okay, so there are some hemoglobins that co-elute in the A2 window, because they all have almost same retention time, so that's why though they co-elute with each other. So then we have how we will diagnose. We will diagnose with the help of the percentages of these hemoglobin variants. Okay, so what is in if it is between 4.1 to 9%, so it is a beta thalassemia trait. Okay, so HbA2 is here, not that one. Then if it is between 10 to 14 or 19%, in that case it will be HB lipore. HBA lipore is actually fusion of delta beta chains. Okay, in that case also there will be a reduced A1 and A2, and increase HbF levels. Okay, so HB lipore, it has 10 to 19% of A2 value. Then it is after that is 22 to 40%, or maybe 50%, it is HBE trait. So just see, it is HbA2 is 32% here. So based on that, this is a scenario of HBE trait. Then after that, if it was between 44 to 48 or 50%, then it would be a case of HBD Iran. Okay, and then it will not be D Punjab. D Punjab has a separate peak in the D window. Okay, then it is 70 to 90%, it will go towards the HBE homozygous. Just remember, like with LED, so like first it will come L lipore. If the percentage increases more, then it will be, after that is E, and after that it is D, LED, and after, if it is 70 to 90%, so HBE homozygous. Just remember this, because you have to solve many scenarios. You can solve many scenarios with the help of these two tables. Okay, so just this is also a revision. So the normal HbA2 is 2 to 3.3%. If a patient has microcytosis and the HbA2 is 4 to 8%, so then it is simply a case of beta thalassemia trait. Okay, but if their A2, the HbF is 5 to 20%, okay, HbA is normal or low, and patient has microcytosis, so then it is a case of delta beta thalassemia trait. If HbA, if A2 is 10 to 15%, okay, 10 to 15%, I just said here 10 to 15%, HbF is raised and there is microcytosis, so would be HB lipore trait. Okay, next is if it is between 25 to 35%, okay, and HbA is reduced to 60 to 75%, so it comes under the here 22 to 40%, it is HbE trait. Okay, so HbE trait would be there. We all include these together because they all will co-elute with A2 because of the similar retention times or closer retention times. Okay, and then if A2 value is more than 85 to 90%, in that case it will be HbE disease or HbE homozygous. Okay, I hope I made the concept quite clear here. Just remember this for your exams, so I hope you will solve many of the scenarios. Next is, the following is the result of a HPLC performed on a woman at antenatal checkup. Same scenario, 12 weeks pregnancy. HbA is here is 52. A2, now you will solve it by yourself. Okay, this is a simple one. HbA is 52, HbA2 is 5.3%, and HbF is 8%. So which of hemoglobin is 9.2? Same, it is a microcytic hypochromic anemia. Which of the following diagnosis is most likely? Same options. So what is the option here? Microcytic hypochromic anemia with HbA2 is 5.3. Here you can see 5.3. So it comes between 4.1 to 9. So it is a case of beta thalassemia trait. Beta thalassemia trait. Okay. Next is, which one of the following hemoglobin mutants will cause a thalassemia phenotype, alpha thalassemia phenotype? So that is a hemoglobin constant spring. Just remember alpha for alpha thalassemia, and this it has a variant of a hemoglobin constant spring. Okay. Next is sickle cell trait is a predominantly benign condition, but there is evidence of for its association with a number of complications. Which one of the following has shown the least significant evidence of association with sickle cell trait? So this are the with sickle cell trait is a quite benign condition, okay, and it is associated with usually the symptoms. Some renal pathologies are associated with this, okay. So these patients have impaired urinary concentrating ability. They are prone to have a renal medullary cell carcinoma, rhabdomyolysis, and splenic infarction. So I think this one, early fetal loss in pregnancy, should not be a complication because it is quite a benign condition. With proper monitoring, these people can carry the pregnancy. So evidence is weaker here. I will not go for this because it is seen in cases of sickle cell trait, okay, when there is exertion or when there is stress. So for me, this one is the option A is not like always associated with sickle cell trait. Next it is also sickle cell trait. So it is a benign condition with a number of complications. Which one of the following has shown significant evidence of association with sickle cell trait? Okay, so again, for the sickle cell trait, which what is associated? So hematuria, yes, it is associated with sickle cell trait. Others, this is associated with sickle cell anemia, okay, when there is sickle cell disease. Okay, just revise this. Strongest clinical associations in case of sickle cell trait is renal medullary carcinoma, impaired ability to concentrate the urine, hematuria, papillary necrosis, splenic infarction at high altitude, and exertional rhabdomyolysis. Okay. Okay, next is 560. Which one of the following mutations has been found in case of Fanconi anemia? So, these are the genetic mutations given in case of bone marrow failure syndromes. So, the mutation associated with Fanconi anemia is BRCA2. Okay, it is FANCD1, one of the FA genes. Okay, there are many genes associated with Fanconi anemia. So, and the others, ATM, it is for ataxia telangiectasia. This DKC1, Turk, and TERT, and another one, this is NOP10, they all are associated with DC, dyskeratosis congenita. Okay, four type of mutations are associated. Like there are other also, but just remember these four here. And RPS19, it is associated with this mutation is seen in DBA, okay, and Turk is again DC. So for Fanconi anemia, we have to go with the option B. Okay, next, which one of the following genetic mutations has not been associated with DC? So I just told you here, DC is associated. DC, the mutations in case of DC is DKC1, NOP10, Turk, and TERT. Okay, RPS19 is with DBA. Okay, just remember these things. These are bone marrow failure syndromes. Okay, DC, it is also a bone marrow failure syndrome in which has very short telomeres. So it is a telomeropathy. The patient will have bone marrow failure, pulmonary fibrosis due to mutation in these genes. Okay, so next question. Erythropoiesis is regulated by erythropoietin, which is predominantly 90% produced by peritubular interstitial cells of the kidneys. So rest 10% is produced by liver. A 2 years old boy presented with severe hypochromic microcytic anemia. Among following, which of the DDU should not include in your list? So in my case of microcytic hypochromic anemia, the four DDs were iron deficiency anemia, anemia of chronic disease, thalassemia, sideroblastic anemia, and lead poisoning. Hereditary spherocytosis is not associated with this. It usually have normocytic normochromic anemia. Next is a 55-year-old male with a history of Crohn's disease, presented with severe pallor and lethargy. Hemoglobin is 6, MCH is 29, MCV 101. What other lab investigations would help you in the diagnosis? So in this case, it's a Crohn's disease. So there is, because of that, there is some malabsorption, and hemoglobin is low, MCV is high. So it is a macrocytic anemia. And for that, we have to go for vitamin B12 levels. Next is a 16 years old boy presented with pallor, lethargy, history of febrile illness, for which he was given chloroquine by his physician. The cells which is shown in the peripheral blood are the bite cells, and reticulocyte count is raised. So it is a case of hemolysis, and most likely after an antimalarial drug. So it is a case of G6PD, and we have to do the test, or G6PD deficiency test we have to do for that. Okay, 566. A 15 years old male presented with pallor, lethargy, RBCs on the peripheral smear that are devoid of central pallor. So they are talking about spherocytes here, because spherocytes are devoid of central pallor. Recurrent pain in upper left quadrant of abdomen, which is due to splenomegaly. Patient has mild jaundice. Which of the following tests will help you to diagnose? So it is a case of hereditary spherocytosis. Okay, and the test we will do is the osmotic fragility test, and it will be increased in case of hereditary spherocytosis. Which one of the following clinical presentation is not seen in G6PD deficient individuals? So, acute hemolytic anemia is seen in G6PD individuals. It is associated with favism. It is associated with chronic non-spherocytic hemolytic anemia, and it is also associated with neonatal hyperbilirubinemia if it is severely deficient, if the baby is severely deficient. So, what is not associated is with option D, because it is a hemolysis, so it should be reticulocytosis, not reticulocytopenia. Next is, which of the following lab investigations will not help you to diagnose unstable hemoglobin disorder? So, reticulocyte count will help to diagnose. Heat instability test, isopropanol stability test, and peripheral blood smear will also help, like we will see the Heinz bodies in that. So the test which will not help if in case of unstable hemoglobin disorder is G6PD assay. Next is a 3 years old boy with an intracerebral cranial bleed is being investigated as a case of possible non-accidental injury. The parents describe a history of previous easy bruising. The boy has a normal blood counts. Blood film is also normal. INR, activated APTT, PT is normal. PFA, platelet function test is also normal. So, which of the following options would be the next most appropriate test? Okay, if I told you before, like if there is a umbilical stump bleed or intracranial bleed, like it is a serious type of bleed, and other tests are all normal, and the test of primary hemostasis, the test of secondary hemostasis, everything is normal. So just think of factor 13 deficiency. So in this case, go for factor 13 levels. Okay. Which one of the following criteria does not form part of the International Society on Thrombosis and Hemostasis recommended scoring system for overt DIC? Number one is elevated fibrin degradation product. Number two is prolonged APTT. Number three is prolonged PT, reduced fibrin and reduced platelets. So, what is not included in this scoring system is APTT. APTT is not included in ISTH scoring system. So, what is ISTH scoring? We do this to see if the patient has an overt DIC or is a compensated DIC. Okay, if the patient has an overt DIC, the score is more than 5, we will go for prompt treatment. If the score is less than 5, so it is a non-overt DIC. Close clinical and laboratory surveillance is needed in that case. And what is included in this? It is PT, platelet count, fibrinogen, and fibrin degradation product marker, like it can be from D dimers or FDPs. So PT, platelet count, fibrinogen, and fibrin related markers. These four markers are included in DIC scoring. APTT is not included. Okay, just remember this. It is for heme residents, I think so. You should just remember if the score is more than 5, it is over DIC, and less than 5 is non-overt DIC. Okay. Okay, these are the transfusion triggers in case of DIC. I have added it for the heme residents, but you can just see if the platelet count is less than 50, but patient is not bleeding, so no need to transfuse in that case. But if the patient is bleeding and there is some infusion invasive procedure, then you have to transfuse the platelets. Okay, in FFP for FFPs, if the PTA-PTT is prolonged more than 1.5 times of upper limit of normal, then in that case, if the patient is bleeding or there is need of some invasive procedure, and then we have to give FFPs to the patient. Okay, if there is no bleeding, then observe only. Cryoprecipitate is decided if the fibrinogen is less than 1 gram, then we have to give cryoprecipitate to the patient. Okay, and hemoglobin, we have to, in case of DIC, If the hemoglobin concentration is less than 7 to 8, so we have to transfuse and keep the maintain hemoglobin between 8 to 9. So in this case, anticoagulation is needed. Okay, if there is a thrombosis predominates, then we have to give unfractionated heparin. Okay, and for prophylaxis, low molecular weight heparin is given. So in case of DIC, we have to monitor 8 hourly these tests. Okay, for the next 48 hours, and then 12 hours once the patient is start improving. So what are the tests? We have to do the platelet count, PTA, PTT, fibrinogen, and D dimers. So this test panel, we have to advise the patient, or we have to advise the ward to just send it every 8 hours for 48 hours, and then if when the patient start improving, it is for every 12 hours this test will be repeated. Next is, which of the following statement regarding von Willebrand factor is most accurate? So binds with high affinity to glycoprotein GP2B3A on the surface of activated platelets. It is wrong. It binds with not 2B3A, it binds with GP1B factor. Okay, GP1B is the complete name is 95, so it binds with GP1B. Circulates predominantly as a very large multimers. Yes, this is correct. Okay, functions most effectively under conditions of lower stress. So no, it is wrong. It needs a high shear stress. Okay, reduce the half life of circulating, it increases the half life of factor 8, and it is stored in viable pellet bodies of the in the endothelial cells, not the neutrophils. So only option B is correct here. Okay. Next is, which one of the following factors show the least association with the plasma levels of von Willebrand factor? So yes, it is associated with ABO blood group. Okay, there is a very strong effect. The patients, the people with blood group O has lower VWF. Then age, it is the age, pregnancy, and stress. They all causes. Uh, increases the von Willebrand factor. Okay, so gender is not like associated with anything with it is not associated with levels of von Willebrand factor. So C is correct here in this option, in this scenario. Okay, next is a 26 years old woman presented with easy bruising, menorrhagia, and recurrent epistaxis. This has been present as long as she can remember, but she is now finding it more troublesome. Her father and parental aunt had similar problems but were never treated. Von Willebrand disease is suspected. Which one of the following parameters is most likely to be normal if the diagnosis is confirmed? Okay, so it's an easy one. In case of von Willebrand disease, what is normal? So APTT, it may be prolonged in von Willebrand disease. Okay, because von Willebrand factor increases the half life of factor 8. So when there is deficiency of von Willebrand factor, so there will be low of factor 8, and then due to this APTT will be prolonged. Okay, then there is a PFA 100 closure time. Yes, it is also prolonged in case of von Willebrand disease. Platelet count is usually normal. Okay, in von Willebrand disease, but it can be low in type 2b. In type 2b, if you remember, we studied that there is a greater affinity between the platelet and von Willebrand factor, so that they stick to each other and then they are removed from the circulation. So in this way, patient have thrombocytopenia. So option E is PT. So PT is not related to that. So PT will be normal in case of von Willebrand disease. So the option E is correct here. Next is, which one of the following criteria would not satisfy one of the Separo clinical criteria for the diagnosis of antiphospholipid antibody syndrome? Okay, so in case of antiphospholipid antibody syndrome, just first remember what is Separo criteria. Okay, so it is that patient has vascular thrombosis, then be arterial or venous, and or the patient has a specific pregnancy morbidity. She must have more than 3 or equal to 3 or more than 3 consecutive miscarriages, less than 10 weeks. Okay, more than one or more than one unexplained fetal death of more than 10 weeks, or okay, and premature birth less than 34 weeks due to preeclampsia or placental insufficiency. So the miscarriages should be 3 or more than 3, and less than 10 weeks. Unexplained fetal death is 1. Okay, which is more than 10 weeks, and premature birth, one premature birth which is before 34 weeks due to some preeclampsia or placental insufficiency. So either this or this should be present for the suspicion of antiphospholipid antibody syndrome. So which one is not correct here? It is this one, E. Two consecutive spontaneous miscarriages in the ninth week of gestation. So it is not two, it should be three or more than three. Okay, so this option is not correct. Okay, so just remember the separoclinical criteria for the diagnosis of antiphospholipid antibody syndrome. Okay, next is, which one of the following factors has been shown to have the strongest association with thrombotic risk in antiphospholipid antibody syndrome? So for in antiphospholipid antibody syndrome, we have three type of antibodies. One is lupus anticoagulant, okay, other is anticardiolipin antibodies, IgG and IgM, and then is other is beta 2, not it is not a microglobulin, the beta 2 glycoprotein. Okay, that is also IgG and IgM type. Okay, so which the one which is more associated, has the strongest association with thrombosis, is actually the lupus anticoagulant. Okay, so among the antiphospholipid tests, lupus anticoagulant positivity has the strongest correlation with the thrombosis risk. IgG anticardiolipin is also important but weaker than lupus anticoagulant. Okay, so it is also important, it after if an LA is positive, we advise the patient to go for anticardiolipin antibodies and beta 2 glycoprotein, but LA is strongly associated with thrombotic risk. So just remember that. Which one of the following statements regarding platelet physiology is true? Okay, so just see here, they are asking about the platelet physiology. So ADP and thrombin are the potent antagonists of platelet aggregation. So they are the agonist of platelet aggregation. When ADP and thrombin is released, so thrombin also go, and with PAR1 and PAR2 receptor, it acts on the platelets and causes activation and aggregation of the platelets. Next is, in platelet adhesion, one of the initial interactions occurred between von Willebrand factor and glycoprotein 2b3a. So it is wrong with von Willebrand factor. It is GP1b95 receptor. Okay, megakaryopoiesis is regulated by the cytokine thrombopoietin. So this one is correct. Yes, megakaryopoiesis is regulated by TPO. Then next is TPO. Thrombopoietin binds to GP1b95 complex on the circulating platelet. So it is wrong. Thrombopoietin binds with its own receptor, which is called TPO receptor, and it is also called MPL receptor. If you remember in essential thrombocytopenia, so cythemia, I explained it like we do mutation, JAK2 mutation. In 50% of cases, JAK2 mutation is positive, but if that is negative, we go for CalR mutation, and if that is negative, we will go for MPL mutation. Okay, so MPL is a TPO receptor. Okay, next is thromboxane A2 stimulates cyclic AMP to reduce cytoplasmic calcium, which results in platelet aggregation. So it is completely the opposite. What do the thromboxane A2 do? It promotes the aggregation by increasing the calcium, okay, and decreasing cyclic AMP. So option C is correct here. Okay, next is, which of the following is not a typical presenting feature in TTP? Okay, just go for TTP. In many scenarios, if you have seen, TTP is an important topic. So I just want to explain it a little bit more to you, and you will get pathophysiology of TTP. Okay, okay. So here they are asking which is not a typical feature or presenting feature in TTP. So hemolytic anemia is a feature of TTP. Neurological impairment is a feature of TTP because there are formation of there are formation of clots which go in the microvasculature, which go into the brain, brain vessels of the brain, and causes hypoxia there, and that's why these patients have neurological impairment. Okay, so PTA-PTT, they say it is prolonged, so this is wrong. It is in TTP, PT and APTT is normal. Okay, so I will tell you why it is normal. Renal impairment, yes, it is associated with TTP, and thrombocytopenia is associated with TTP. So option C is here. If you see here, it is a vessel. I made a vessel, and this is a platelet plug. Okay, it is a platelet rich microthrombi. So this in case of TTP, there is a deficiency of ADAMTS13 enzyme. Okay, this deficiency, if it is a congenital TTP, So this the person has a deficiency of ADAMTS13 enzyme, and if it is a secondary TTP, then the patient has developed antibodies against this enzyme, and that's why due to antibodies this patient has deficiency of ADAMTS13. Okay, so whenever but what is whatever there is the reason, when there is deficiency of ADAMTS13, so there what will happen, there will be uncleaved ultra large von Willebrand factor multimers. Okay, ultra large factors which are released from the which are released from the Weibel-Palade bodies of the endothelial cells, and they are also released from the alpha granules of the macrophages. So they are very large, and just remember they are just like super glue. Okay, when they are released in the circulation, they will aggregate platelets around them and form a microthrombi. When a microthrombi is formed here, when the red cells will pass through, many red cells will stick to this, and the other cells which pass through them, they get sheared off, and that's where they are fragmented, and we call them schistocytes or fragmented RBCs. Okay, so one is the one complication is that there will be microvascular thrombosis. Okay, and the other thing is due to deposition of platelets in this thrombi, patient will have also thrombocytopenia. So because of thrombosis there will be end organ ischemia, and the organs most commonly involved is heart. The patient will have MI, the patient can have arrhythmias, the other organ involved is brain. Okay, so patient have that's why neurological symptoms, and the other is acute kidney injury. So in kidneys also we have that small vessels, and patient will develop acute kidney injury or failure. Okay, so this just remember this, it's a microthrombi, uh, platelet rich microthrombi, and this is a fibrin rich microthrombi. It is a thrombi in case of DIC. You can see the fibrin around it. Okay, so that's it. In this case fibrin is formed, so it means coagulation factors are consumed here. So because of how fibrin is formed, of course thrombin will form, and all after going to all intrinsic extrinsic common pathway we will have fibrin. So all coagulation factors are consumed here that's why in DIC PT and APTT will be prolonged. But in case of TTP, if you see, just remember this diagram, there is no thrombin here, and it is a weak type of plug. Okay, what will happen that if it go in the brain, and it is it and it causes hypoxia, their patient will have some neurological symptoms, but it is just loose type of clot, it will dissolve, patient will again will be okay, and after some time again the clot will form and patient will have the same symptoms. But this type, it is a very type of strong type of fibrin plug, the thread is wrapped around it, it will not dissolve. Okay, so TTP is this type of plug, and in DIC we have this type of plug. I hope now you got a clear concept of pathophysiology of TTP, because these patients in TTP there is a high mortality rate. So we have to treat these patients before we get the true ADAMTS13 levels or something. Just we have to see, there is a scoring system, plasmic scoring system. We will do that, and we will suspect it is a case of TTP, and we will go for plex. Okay, so plex is urgent plasma exchange. We will remove the autoantibodies. If the autoantibodies are formed, then we will remove the autoantibodies. We will also remove the ultra large von Willebrand factor multimers, and we do plex with FFPs. So in that we will replace the ADAMTS13. Okay, so in this case patient can improve. And secondly, it is because autoantibodies are there, so we will give steroids to the patients, and we will can give this capelizumab plus rituximab. Okay, so these are for the heme residents. Just if for the other, I think so, and this is enough. Okay. Okay, so if plex is not available or is delayed, ongoing microvascular thrombosis will cause death. Without plex, the death rate is 90%. Okay, so it is a medical it is an emergency. We have to take these type of patients very seriously. If we have schistocytes in the peripheral blood smear and we have all those symptoms, so we have to go for the plex. Okay, next is, which of the following statement regarding the INR and the ISI is true? Okay, so INR, each laboratory should use the reagent thromboplastid manufacturers recommended ISI in order to determine the INR. Okay, the ideal ISI values are greater than 1. No, should be closer to 1. INR is the standard means of a reporting prothrombin time in any hospitalized patient. No, we do in the patients who are on warfarin. Okay, not all the patients. The mean PT is used is deriving the INR should be determined from at least 20 blood samples derived from a local population of people not on warfarin. So yes, this option is correct. Okay, so mean PT should be obtained like this. The ratio is calculated by the formula. This formula is wrong. The formula is like patient's PT divided by mean PT, the normal PT, and multiply by ISI, and we will get the INR. Okay, so next is 72 years old male diagnosed case of CLL presented with pallor, lassitude, weakness. On examination, he is pale, generalized lymphadenopathy and hepatosplenomegaly. CBC reveal HB is 2, HB is 5.2, WBC count is 90. It is raised because of the lymphocytosis. Platelet is 75, so it is bicytopenia. What is the possible cause of anemia in this patient? So the most common, like if the symptoms have been uh, person. Okay, patient has pallor, patient has splenomegaly, hepatosplenomegaly, patient has anemia, platelets are also reduced, so it may be due to infiltration of the bone marrow with a lot of lymphocytes. So patient have a because of that patient has developed bone marrow failure, so A is correct here. In CLL, just remember in CLL, if the patient is not symptomatic and patient is fine, there is no autoimmune hemolytic anemia or any complications, so we don't need to treat the patient. But there is like if there is long standing CLL, patient can have the transformations. One transformation is called Richter's transformation. Okay, in that case, about patient will the CLL will be transformed into DLBCL. Okay, and it can also transform into Hodgkin's variant, Hodgkin's lymphoma, and there is 15 to 20% will transform into CLL, PLL, and then to BPLL. Okay, so just remember that CLL will transform into go into Richter's transformation, which is DLBCL in 99% of cases, and in less than 1% it can transform into Hodgkin lymphoma. And for a CLL, PLL, or BPLL, 10 to 15% may evolve into this. Okay, and there are what is CLL, PLL? In that case, 11 to 55% there will be pro lymphocytes, bigger lymphocytes with a prominent nuclei in the blood, and when they are when if the pro lymphocyte is more than 55%, then it is BPLL. And if you do the immunophenotyping here, so FMC 7 will become positive, CD20 will be strong positive, and surface immunoglobulin will also be strong positive, which was weaker in CLL. Okay, so just remember this concept. Next is a 42 years old woman has noticed during the past month that even minor bumps produce major bruises over her body. On physical examination, she has areas of purpura on the skin of her arms and legs. She is afebrile. Okay, lab studies show PT of 12, APTT 26 normal, CBC HB 11, a hematocrit 33, MCV is 84, platelet count is 790. So it is platelet count is raised, WBC count is also raised 45. A bone marrow biopsy is performed and show hypercellularity with myeloid and megakaryocytic hyperplasia. Okay, so which one of the following is most likely diagnosis? So when there is WBC count is raised, myeloid lineage is raised, megakaryocytic hyperplasia, so it can be a case of MPN, myeloproliferative disorder. Okay, so option B is correct here. Next is a 4-year-old female, 46-year-old female was found to have high platelet count on CBC. She was investigated for the hypertension due to family history of ischemic heart disease. Her general physical examination was unremarkable. CBC showed WBC of 10, hemoglobin 12, platelets 980. Peripheral smear showed a normal differential and increased platelet with some giant forms. Routine investigations were normal. LDH was slightly raised. Ultrasound abdomen normal. What is your most likely diagnosis? So in this case, if you see there is isolated platelet count is raised. Okay, so WBC count is also normal, and HB is also normal. So it can be a case of essential thrombocythemia. In that case, if you do the bone marrow, we can see the uh, large forms of megakaryocyte, the staghorn forms. Okay, of we will see in case of essential thrombocythemia. Okay, if there was pan myelocele, WBC count, HB, and platelets, everything is increased, and then we can consider like it can be a case of polycythemia rubra vera. But here, when there is isolated platelets only prolonged, so it is a essential thrombocythemia. Further, we will do the mutational analysis to confirm. Okay, a 57 years old man presented with history of generalized weakness, pallor, and blood transfusion after every 2 months. CBC showed hemoglobin of 7.5, platelets 62. BMA showed hypercellular marrow with dysplasia in all three lines. IPSS score of this condition includes all of the following except. So it is a case of MDS, and in IPSS, what is included? Just remember CBC. Okay, cytopenias are included. Okay, blast percentage is included, and cytogenetics is included. Okay, so dysplasia is not included in IPS's international prognostic scoring system. We will go see, we will go, see the cytopenias, the blast percentage, and cytogenetics, CBC. Okay, next is a 55-year-old male presented with gum bleeding and pallor. His CBC showed hemoglobin of 6, platelets of 18, neutrophil zero point 0.7. So everything is low here. Biopsy also show that it is a hypocellular. He was diagnosed as a case of aplastic anemia, right? Which of the following treatment can give of a permanent cure? So the permanent cure is allogenic bone marrow transplant. Okay, if we can give it to the patient. And the other supportive treatments are, we can give anti-thymocyte globulin, cyclosporin, GCSF, hematopoietic growth factors, and iron chelation. Okay, these are the supportive treatments in case of aplastic anemia. Next is, in a clotting mechanism pathway, thrombin activates the factors. Thrombin activates which factors? It activates, just remember, 11, 5, and 8. It also activates factor 13 to factor 13A, and it also activates platelets and protein C to activated protein C. So just remember this, because thrombin is a very important factor among the coagulation pathway. So it blocks the coagulation pathway by acting on factor 11, 5, 8, 13, platelets, and also protein C. Next is, a clinically well 14-year-old girl had an incidental blood count performed. The CBC and platelet count were normal. HB and red cell indices were RBC is 3.2, HB is 138. Okay, so it is erroneously prolonged. MCB 115, MCH 43, MCHC 376. The blood film prepared from the same blood specimen appeared normal. The most likely explanation is, so it is the EDTA dependent red cell agglutinin. Okay, so because of the EDTA, there is agglutinations, and the CBC analyzer gave these values. Okay, so it can, in case of agglutination can also occur in case of cold agglutinins when there are antibodies, IgM antibodies, and in that case we will see there is agglutination on the peripheral blood smear, and when we warm the sample and then repeat making the smear, so agglutination will go. Okay, so this is a case of EDTA dependent red cell agglutination. Next is, an anesthetist was referred to medical OPD with complaints of severe anemia and lethargy. Okay, so his CBC showed macrocytic anemia and bone marrow biopsy was hypercellular. He is likely to be relieved by which of the following medication? So it is like operation theaters, there is nitrous oxide. Okay, they are exposed to the nitrous oxide, and nitrous oxide causes inactivation of vitamin B12. Okay, so these patients will develop these people will develop megaloblastic anemia, and there will be macrocytosis with hypercellular marrow. So treat the patients with vitamin B12. A 36-year-old male presented with a sudden onset of pallor after an acute febrile episode for which he took penicillin. All of the mechanisms are responsible for drug-induced hemolysis, except, okay, so drug-induced hemolysis also occurs, and what is the mechanism? So drug adsorption, okay, immune complex mechanism, autoimmune mechanism, and membrane modification. So these are all included in drug-induced hemolytic anemia, but mechanical fragmentation, which is MAHA, is not included in this. It is not related to this. Next is, all of the following are classified into hereditary hemolytic anemias except. So hereditary hemolytic anemias, it is hereditary spherocytosis, G6PD, sickle cell anemia, and unstable hemoglobins. They are associated with hemolysis. Okay, hereditary type of hemolysis, because of the like it they are hereditary. But this PNH is acquired clonal stem cell disorder. We read it so many times. So it is acquired, rare, and clonal stem cell disorder. Next is you were asked to consult on a newborn on day 2 of life due to excessive bleeding after circumcision. The APTT is prolonged, PT is normal. Factor essays and the results are as follows. Factor 8 activity is 12%, 9 is 52, 11 is 65, 12 is 96. The most likely diagnosis is, so the normal activity of these factor levels should be more than 50, and they are around like 50 to 150%. Okay, so if they are less than 50, then it means there is a deficiency. So here factor 8 levels are 12, so it is a deficiency of factor 8. Next is a 8-year-old female with recurrent tonsillitis is referred to for tonsillectomy. Her surgeon orders preoperative lab tests, and the results demonstrate that PT is normal, APTT is prolonged. The most appropriate next test to order is, okay, so this APTT is prolonged, PT is normal. Okay, so what we the next step we will do is we have to do the mixing studies. We will take the patient plasma and we will take a normal plasma and we will do 1 to 1 mix. If it corrects, it means there is a deficiency of there is factor deficiency. Okay, and then we will do the assay, specific assay to know how much that factor is deficient. Okay, so next is a 52 years old man on warfarin for recurrent venous thrombosis. The patient came with an INR of 8 with no history of bleeding. What will be your management plan in this patient? So if the patient is on warfarin and the INR is 8, okay, and but there is no history of bleeding, so what will be your management plan? So in this case, INR is um, like it should be 2 to 3, but here the INR is 8. So in this case, what we have to do, you have to stop warfarin and give patient vitamin K. It is a reversal of warfarin, so you have to give the patient vitamin K orally. Okay, so just remember this table. I think so it should be for the heme residents, but I want this to revise with you guys. Just go through that. If the patient is taking warfarin, okay, we will do INR. If the I and the target value is usually 2.2 to 3. If it is more than 3, like 3.3 to 4, but there is no bleeding, just you have to skip one dose and just adjust the dose. Okay, reduce the dose a little bit and no reversal is needed. If it is between 4 to 5 and in patient is not bleeding, so also in that case also just omit one dose and at a lower dose again restart the warfarin. Okay, so in this case also no reversal is needed. Yes, if it is between 5 to 9 like it was in our scenario, but patient is not bleeding, but now it is between 5 to 9, so stop warfarin for 1 to 2 days and then start with the maintenance dose. Okay, and but in this case we have to give small amount of vitamin K. Okay, so we will give from 1 to 2.5 milligram oral vitamin K to the patient. Okay, next is if it is between 9 to 10 and still no bleeding. Okay, so then stop warfarin. We have to stop the warfarin, and we there is but in this case we know there is high risk of spontaneous bleed, so we will do the reversal. In this case we have to give 2 to 5 milligrams of oral vitamin K to the patient, and we can give 0.5 to 1 milligram IV vitamin K if there is a high risk case of or in the hospital settings. Okay, next if there is any INR, okay, any INR 4, 5, 6, 7, 9, 10, but if the patient has bleeding, okay, minor bleed, epistaxis or bruising, so just stop warfarin and give 1 to 3 milligram of vitamin K orally or IV depending on the setting. Okay, treat the bleed. Okay, you have to treat the bleed and give the reversal. Next, if any INR but there is major bleed, stop warfarin immediately. First of all, you have to stop warfarin and then do the reversal. In case of severe bleed, we have to give a prothrombin complex concentrate. If it is not available, give FFPs because that will provide the clotting factors, and just do the reversal by giving 5 to 10 milligram IV. In this case, when there is major bleed, you have to give vitamin K IV 5 to 10 milligrams IV. Okay, so this is emergency reversal, and you have to do the reversal and stop warfarin. Next is The vitamin essential for blood clotting is vitamin K, because it is needed for gamma carboxylation of 2, 7, 9, 10 protein C and S. Next is which what prevents clotting of blood vessels, blood in the vessels. So heparin in the body, there is heparin sulfate, so which prevents the clotting of blood in the blood vessels. Okay, which statement is false about antithrombin deficiency? So when there is antithrombin deficiency, so there is prothrombotic stage, there will be thrombophilia, causes recurrent venous thrombosis starting in early adult life, so it is correct. Warfarin potentiates the effect of antithrombin, no, it is heparin, so this one is wrong. Okay, protein S is not a cofactor for antithrombin 3, it is correct. Antithrombin concentrates are available, it is right, and it is an autosomal dominant, AD, autosomal dominant. Which of the following is correct regarding low molecular weight heparin? So, in the hospital settings, we use unfractionated heparin, and we also use low molecular weight heparin. So, which statement is correct regarding low molecular weight? Has an average molecular weight of 15,000 to 18,000? No. Inhibits factor 10 more than the thrombin. So, this is correct. Okay, it inhibits factor 10 more than factor 2. Now, and third is causes heparin-induced thrombocytopenia. The risk is lower in case of low molecular weight heparin and increased in case of unfractionated heparin. Has a shorter half-life compared to, no, the half-life is increased, is more as compared to unfractionated heparin. Requires routine monitoring. Routine monitoring is not needed in case of low molecular weight heparin or clexane, which we give it to the patient. In that case, we don't do APTT test. But yes, if you give unfractionated heparin to the patient, in that case we will do the monitoring by APTT. Okay, so just for a low molecular weight heparin, remember it is low molecular weight, so it is a smaller size. Instead, molecular weight is 4 to 6 kilodaltons. Okay, not 15 to 18, and it causes factor 10 inhibition more than factor 2. Okay, factor 10 inhibition is more than thrombin. And how we will see the levels? We will do NT10A levels. It is not written here, so we will do, and yeah, here monitoring is done by NT10A, not by APTT, and it has a longer half-life than unfractionated heparin, and the risk of hit is lower in case of unfractionated, is lower in case of low molecular weight heparin. It is increased with unfractionated heparin. Okay, which two factors are identified by the name instead of Roman numerals? So calcium and labile factor, factor 5 and 8 are labile. Calcium and Stroud prover factor is factor 10. Fibrin stabilizing factor, prothrombin is factor 2. Higman factor and Higman factor is factor 12, and uh, pro-convertin. So I didn't hear about this. Then it is pre-kallikrein and high molecular weight kininogen. So they are no Roman numerals are assigned to them. So they have some other difficult names. So pre-kallikrein is also called Fletcher factor, and high molecular molecular weight kininogen is also called Fitzgerald factor. Okay, so just in case it I don't think so it will come in exam. Okay, the process where fibrin deposits are removed to restore circulation in the blood is called fibrinolysis. Okay. Next is a 72 years old male diagnosed case of CLL presented with pallor, lassitude, weakness. So it is the repetition. It is the same scenario which we did above. Like it is a bone marrow failure case. Okay, because of the infiltration by the lymphocytes, the patient has gone into bone marrow failure, and all the cell lines are decreasing. Then is hemolytic anemias are caused by, so hemolytic in hemolytic anemias, what is the mechanism? There is excessive destruction of red blood cells. So option D is correct. Next is 600. A 40-year-old man presents with DVT on the left femoral vein. His autoimmune profile is also positive, ANA and NTDS DNA. In addition, lab test was done, so lupus anticoagulant was positive. There is no family history of venous thrombosis, but patient has developed thrombosis. Okay, so he presented with thrombosis to you, and there is autoimmune disease associated with this, and then the lupus anticoagulant is also positive. Special coagulation testing confirms the presence of LAC. What is the most reasonable duration of warfarin anticoagulation for this patient? Okay, so here they give the option 6 months, but it should be long term anticoagulation because this patient has developed thrombosis, and this patient has autoimmune disease and LA is positive. So whenever there is a history of thrombosis, so in that case we have to give a long term treatment with warfarin by monitoring it with INR. Okay, so now warfarin is the first line treatment in case of antiphospholipid antibody syndrome, usually lifelong in thrombotic cases. Okay, DOACs are not recommended, especially in triple positive. If there is triple positive, LA is positive, anticardiolipin and beta 2 glycoprotein, everything is positive. So in that case, DOACs are not recommended because studies show that there is increased thrombotic reoccurrence with DOACs compared with the heparin. That's why in case of these antiphospholipid antibody syndrome, we give patients warfarin, not DOACs. Okay, so just it is a repetition of the same in APS diagnosis. What should be present? If there should be one clinical event, one laboratory finding. The clinical event should be the patient. There should be one should be must. There should be venous thrombosis, DVTP or arterial thrombosis history, or patient has pregnancy morbidity, more than 3 miscarriages, less than 10 weeks, more than of one fetal death after 10 weeks, and premature birth before 34 weeks due to severe preeclampsia or placental insufficiency. So any one of the criteria should be present from here, and in the laboratory anyone should be present from here. Lupus anticoagulant positive or anticardiolipin antibodies or beta 2 glycoprotein should be present. Okay, and these tests should be performed twice and 12 weeks apart. Only then we will say that APS is confirmed, because there is also transient positivity of LA. When it will temporary, they will increase, and then after that they will go to normal by themselves. And what are those infections? They are viral infections, dengue, malaria, tuberculosis, HIV, certain drugs, after vaccines and elderly population. So these patients do not have antiphospholipid antibody syndrome. So we don't give warfarin to these patients. That's why we say we have to do the test again 12 weeks apart, so just so to confirm the disease, and then we have to start the anticoagulation in that type of patient. So if the patients have history of thrombosis, okay, or a triple positive, so they need lifelong warfarin treatment. Okay. Okay, next is a 73 years old woman presented with new onset back pain for the last 3 weeks. Her medical history is significant only for hypertension. X-ray shows lumbar spine showing osteolytic lesions in L2, L3, L5 region. Lab values are as follows: hemoglobin is 9.3, WBC 4.6 with a normal differential count. The platelet is 230, ESR is 110. So it is normocytic normochromic anemia. It is anemia here. ESR is raised. Creatinine 1.5, calcium is raised. Okay, 12 point, it is 13.1, and patient has osteolytic lesions. Albumin is 2.6. Albumin will be reduced in case of myelomas. Okay, so what is the most likely diagnosis? So in this case, you should be knowing that there is it is a case of plasma cell dyscrasias, and the patient has end organ damage. Calcium is raised, osteolytic lesions are there, hemoglobin, it is anemia is there. Okay, the features of crab are present. Okay, so in that's why it is a case of symptomatic myeloma or plasma cell myeloma. In MGUS there is no and organ damage, so no crab. Okay, next is I a 67 years old man, dull pain in his left right back for the past 4 months. A CT scan shows a yes, a mass on the upper right kidney. HB is 21, hematocrit is 64, so it is a case of polycythemia. Platelet count is normal, WBC count is normal. These are biochemical tests are also normal. Which of the following is most likely the cause of his symptoms? So the cause of his symptoms is this renal cell carcinoma, and which release EPO, and because of EPO there is secondary polycythemia in this patient. Okay, in case of polycythemia vera, remember EPO will always be low, and it is one of the minor criteria given in WHO for the diagnosis of polycythemia vera, that it will have suboptimal levels of EPO. Next is a 4-year-old boy diagnosed as a case of thalassemia major receiving regular transfusions each month was on iron chelation therapy. So iron chelation therapy reduces the labile plasma iron. Yes, it is correct. So A is correct here. Okay. With defroxamine is associated with CNS toxicity. It is usually associated with ocular toxicities. Defriprone prone, these patients are prone to cytopenias, usually neutropenia. Okay, and with the DEFRA Cirox is done thrice. No, it is OX. Just remember OD. It is given once daily. So here option A is correct. Next is a 7-year-old a known patient of thalassemia major went under splenectomy an year ago. If not properly vaccinated, okay, so these patients are likely to develop infections with encapsulated bacteria. So where is the it is H influenza here. Okay, a 54-year-old man is diagnosed to have atrial fibrillation and started on warfarin therapy. 5 days later, he developed large patches of dark colored skin over his legs and gluteal region. His CBC is within normal limits. PT is prolonged. APTT is normal. The most likely cause of this presentation is drug allergy, antithrombin 3 deficiency, very high INR, protein C deficiency, and factor 5 lead-in mutation. So here it is protein C deficiency. Warfarin initially drops protein C faster than other procoagulant factors. So there is a transient hypercoagulable state, and skin patient will have skin necrosis, especially if the patient has underlying protein C deficiency or protein S deficiency, or there is it is a high loading dose of warfarin. Okay, or we are not bridging it with heparin, and these spots will be seen in the areas which have more fat content, like breasts, buttocks, or thighs. Okay, and these are painful necrotic skin patches. Okay, and the time usually is 3 to 5 days after starting the warfarin therapy. So we have to immediate management is we have to stop heparin therapy. Okay, and we have to give vitamin K to the patient, and we will start with heparin, and you can give protein C concentrate to the patient, or FFPs if it is severe. Okay, so from it is the last MCQ of the hematology section. So I am happy that it is finished. So inshallah we will start with transfusion. I think so transfusion have 300 MCQs, so I'm excited to start that. Inshallah we will start in the next week the MCQs of transfusion. Okay, thank you so much.